Watch your step here. Oh, hey, guys. Please take a seat. Folks, my name is Joe Biden. I'm Jill Biden's husband, and I'm delighted you all are here. I know this is highly unusual what I'm about to do, but before we begin, I'd like my entire staff to come out here for a minute. Is the staff back there? Greg? Have them come out because all I can see is the back of my bald head. Come on, bring the whole staff out. Come on up. Folks, this is Greg, Danielle, Catherine, Cecilia, Lisa, Ariel, Katie, Malloy. I go through the whole list, but you see this group right here? They've been working on this effort for the better part of a year. They put everything together. The most important thing I like about these guys is not only they're smart as can be, but they put their whole heart and soul into this. They care about it. It matters. And I want to publicly recognize them. I want you all to give them a round of applause because they're the reason this is happening. Greg, thank you. This is the boss man right here.
Thank you.
Now that I've thoroughly embarrassed them, thank you, guys. Thanks for a great job. Folks, welcome. And I want to say welcome to the more than 450 summits that are going on all across America. In every state in the union, there is a summit taking place all day today and right now as I speak. And folks, I want to thank my former colleagues, Democrat and Republican, many of whom are hosting summits from Southern California to Connecticut at Yale University now, all across America. And this is the last, and hopefully will not remain the last, but this is the one bipartisan thing that is still left in America. Republicans as well as Democrats feel strongly about, one, the opportunity we have to break through and change cancer as we know it, and two, are committed to finding the resources to be able to do it. And so I want to thank them. And I'd like to suggest that I think we had a great day today. And in the weeks and months ahead, we're going to see the fruits of the labor that all of these people, including the panel I'm about to have introduced, we've done some really good things. Folks, there's hope. There's genuine hope. There's a lot that's happening. And one of the things we want to do is make sure that we communicate to all the folks in the country that we're going to be able to do in the next 5 years what's going to take, what otherwise would take a decade. And it's already beginning to happen. And this evening, I want to speak directly to the public at large, not just all the experts we've had here today participating. Because, cancer presents a complicated maze. Many of you, if the lights were up, I bet if I asked for a show of hands in the audience, in the balconies, and ask you if you or anyone close to you has suffered from cancer, you lost them, I bet you, as usual, 70 to 80% of you raise your hand. And you know what a maze it is when you hear that dreaded phrase, it's cancer. It's cancer. And one of the things we've spent a lot of time trying to do is try to help people who are overwhelmed by that diagnosis and overwhelmed by what follows from it to be able to get through it. And so I've heard today from the experts, from physicians, from nurses, from people who are both survivors as well as the caregivers. And I know you all have more questions. And so I wanted to, with the help of the experts behind me and the 3 panels you'll hear from tonight, I wanted to give an opportunity for folks online, and there are close to 1,000 people who have sent in questions so far. We're not going to be able to answer 1,000 questions, but I wanted to be able to hear from the experts your answers to your questions. Because again, I don't want to exaggerate it. We're not there yet, but we're making enormous progress, enormous progress. And today, what happened here as well, there are a number of over 50 commitments were made that would change the lives of families undergoing this. For example, one of the problems people have is you have a mom or a dad who's a single parent undergoing chemo or going treatment, and they have no one to take care of their kids when they go for treatment. Or people who can't afford the drug they most need in order to best fight their cancer. Or families who have to go a distance in order to be able to get the treatment they need, and the transportation is not available to them. We had everyone from a group that is going to provide free air travel for families that have to go a distance to, for example, Airbnb is guaranteeing that if you have to leave your community to go get help, they'll provide housing for you while you're there. We have the Lyft and, who am I leaving out? Uber guaranteeing when you're you're out of your city, providing transportation for all you need while you're there getting treatment. These are things that change people's lives, allow them to be able to go forward and get the kind of treatment they need. We also had a lot of help from, we have nurses and doctors, but we need to have people who can help people travel through the maze. And so we put together programs that are going to just, I think, change families' lives. But with that, why don't I, as my mother would say, hush up and start and turn this over to Carol Brown, Dr. Brown, and let her tell you about this panel, and they'll be prepared to answer your questions. And so I'm yielding to you, Doc, and thank you all very much. And by the way, this is a nurse. I can tell you, if there are any angels in heaven, they're all nurses, male and female. Doctors allow you to live. Nurses want to make you live. I had 2 cranial aneurysms, major embolism, a month in ICU, 7 months in the hospital, my son a year in the hospital, my deceased wife and daughter. Nurses get you through. Thank you, thank you.
Thank you so much, Vice President Biden. Good evening, I'm Carol Brown. I'm a GYN cancer surgeon, and I work at Memorial Sloan Kettering Cancer Center, and I'm just delighted to be here with you this evening, and I'm going to let my wonderful expert panel introduce themselves, and then we'll get to your questions.
Well, good evening. I am Sylvia Trent Adams, Rear Admiral Sylvia Trent Adams, and I am the Deputy Surgeon General.
Hi, I'm Dr. Regina Benjamin. I'm a family physician. I'm now practicing in Biola Battery, Alabama, back at my clinic. But I was the 18th United States Surgeon General under President Obama and Vice President Biden. And we released the first ever national prevention strategy.
Good evening, buenas tardes. My name is Dr. Elmer Huerta. I'm the director of the Cancer Preventorium at the Washington Cancer Institute, MedStar Washington Hospital Center here in Washington, D.C. And I'm very happy to be here. Thank you.
Thank you so much, panel. So let's get started with our first question. Our first question is from Vicky on Facebook. Vicky tells us, I work on cancer prevention efforts at the state and local level, often in collaboration with healthcare providers, schools, faith-based communities, employers, agencies, and public health districts. Salary and budget cuts, both locally and nationally, have negatively impacted the advancements that we've made in raising awareness and reducing cancer risks. What is currently being done, or what could be done in the future at the national level, such as at the U.S. Departments of Education, Health, Labor, Veterans Affairs, to ensure cross-collaboration to help identify opportunities and address the issues that might hamper our fight against cancer, such as budget cuts, silo mentality, and partisan politics? And that question is for Rear Admiral Adams.
Thank you. I think one of the most important aspects of the national level of healthcare is that we must build collaborations across the federal space. And what I mean by that is creating opportunities for those departments of education, health and human services, as well as many of these sectors such as Department of Transportation to work together to build strategies where communities can be empowered to build those programs that can be more sustainable, but by creating cost savings through lack of duplication of efforts.
Great. Our next question is from the crowd, from Heather. Do we have Heather to ask her question? There she is. Hi, Heather. What's your question?
My question is that HPV causes cancer in all genders, including one of the fastest increasing cancers in American men today, oral cancer. Now that we have a recommended vaccine, a cancer vaccine, even though we have that, uptake is below that of other adolescent vaccines. How do we create urgency amongst key stakeholders such as parents as well as insurance companies to demand that all children are protected against HPV-related cancers?
That's great. So that question we're going to direct to Dr. Huerta.
Thank you, Carol. Well, I think that what we need to do is to empower people with the one tool that people, all of us need in order to go ahead with our life, which is education and information. If the same way that they say that democracy dies in darkness, I believe that science also dies in darkness. So the light that we need to put there is education and information. But that education and information, in addition to the classical, traditional media, the television, the radio, etc., in my opinion, needs to be at the local neighborhood level. In my hospital here in Washington, D.C., I work from, if I go to the 7th floor of my hospital, I can see the Capitol right there. We have doubled the national rate of advanced breast cancer. In our hospital, Washington Hospital Center, 22% of all the cases of breast cancer are stage 3-4. Nationwide, it's only 10%. When we went to find out who those women were, we found out they live in the neighborhood, African American women, and surprisingly, 97% of them do have health insurance in their pockets. So having access to health insurance is not enough. What we need to do is to light their lives with information and education. In my same hospital, in my clinic called the Cancer Preventorium, for the last 24 years, we have a clinic that called the Preventorium, that when we started had a sign at the door that said, if you want to come here, you have to have no symptoms, because this is to talk about prevention and to do cancer screening. We have seen almost 37,000 people there, 95% of them Latinos. They are poor, and you know what? 85% of them, they have no health insurance, and they pay out of pocket to get screened without symptoms. Why? Because for the last 25 years, they received a 1-hour radio show in Spanish for them on education. So you have the two sides of the coin. You have the side of people who have education, they pay out of pocket to get screened, and then you have the side of people who have access to health insurance and they go late. So the HPV is the same thing, but we need to go to the neighborhood, because in the same way that Vice President Biden said before that we need to have precision medicine, studying your genome and finding the right medication for you, I can tell you that every community also has a DNA, and we need to go there, but you know what? With people who live there, because they know their community.
Exactly. Thank you so much. I think that the issue of HPV is actually very critical, and I think that what I hear you saying is that communication and awareness is really one of the cornerstones to being able to increase the uptake of the HPV vaccine. Our next question is also from the audience. Our next question is from Eddie. Eddie Gonzalez.
This is me, right here.
Hi, Eddie. How
Hi,
are you?
I'm doing all right. I'm Eddie from Harlem, New York. And my question is about social determinants and partnerships. We know that access to quality medical treatment, prevention, survivorship resources are often tied to non-medical factors like housing, employment, and the actual physical environment. So I'm wondering, what are some of the partnerships that you find most promising, and where do you find some of the areas between non-medical and medical partnerships that we need to do more work?
So can I take that?
Absolutely. This is for Dr. Benjamin.
So, right. I always say that health occurs every place, not just in the doctor's office or the hospital. It occurs where we live, where we learn, where we work, where we play, where we pray. It's in everything that we do, and the partnerships are so important. And I'm going to digress just a minute and say that most people don't know what the Public Health Service does. And so as the United States Public Health Service, our officers are 6,500 around the world who, whereas the Navy protects our shores, the Air Force our skies, the Public Health Service protects the public's health. And those partnerships we could really utilize. So I was really proud to leave the Public Health Service in the hands of someone like she's got a double name, it's Trent Adams, so, and I usually call her by her first name. So. But that's one of the partnerships, and I think we could utilize the Public Health Service in this. When I went back to my clinic in Bayou La Battery, Alabama, I started the Gulf States Health Policy Research Center. And one of the things we noticed is that the states that border the Gulf of Mexico, Alabama, Mississippi, Louisiana, Texas, and Florida, have the poorest health outcomes and the health rankings. Yet we have wonderful medical schools, we have wonderful clinicians, but why? And the only way to learn is through research. So we started doing health policy research. We've organized over 150 organizations, community-based organizations, churches, schools, PTAs, to start to look at this. And we are doing community-based participatory research. And those people are so excited, just like what you're saying. We have to involve them. And yet, a lot of our research is not funding these. We can give a $500 grant and get so much done. Just little things bringing organizations together. And so those kind of partnerships, I think, are so important.
Rear Admiral Trent Adams, do you have any examples of effective partnerships between the community and the Public Health Service that you can tell Eddie about that you think will be a good model for this?
Absolutely. One of the initiatives that we undertook for many years in the Public Health Services, we partnered with a nonprofit organization. Many of you may know about Remote Area Medical, also known as RAM. In the Public Health Service, under the leadership of the Surgeon General, we go into underserved communities where there is a limited access to care or a high rate of uninsured, large gaps in care where there are huge disparities, as well as individuals who may not have ever had access to certain specific services, such as oral health care, dental care. The Public Health Service partners with the community to set up a space, and we may take over a university's gymnasium for 3 to 4 days. Typically, it runs 2 to 3 days. And just this past June, we went into southeast Oklahoma. We served 800 clients over the span of 2 days. And we worked with RAM and the university there to provide everything from general screening for cancer, HIV, as well as did some opioid interventions. And we also worked to provide dental care and make eyeglasses on the spot for individuals from all over that area. But what was touching for me, having been raised in the public health mindset, was that many of the people articulated that they drove from 3 states away to be able to get their first pair of eyeglasses in 3 years because they didn't have the money to be able to replace the glasses that they'd lost or broken. And in the Public Health Service, that's what we do. We go into these communities that are underserved, and our mission is to serve the underserved. As a uniform service, we're like the best kept secret. We're the only uniform public health entity across the world. And what we do every day is we serve in agencies such as CDC and NIH. I spent the vast majority of my career in the Public Health Service after leaving the Army in HRSA, building HIV programs all across the world. And that comprehensive model of serving the underserved is what works best. Empowering communities to understand what their needs are, articulated to the leaders, and building systems that are sustainable over time. As Dr. Benjamin indicated, it takes leaders to take the stance that we want to help, but you have to listen to the community and meet them where they are. And that's how we build communities of collaboration and systems that are sustainable over time in coordination with the Public Health Service and the communities where we are serving.
That's excellent. Dr. Huerta, can you elaborate on some of the environmental factors that you found in your area that you're serving that might influence prevention for cancer?
Yeah, when we went to the community, because once we found out that 97% of these men and women with colorectal cancer and women with breast cancer had advanced condition and all of them were insured, we went to the community with community health workers. They are a wonderful, wonderful tool that is completely underutilized. Who is better than a person who lives in the community to knock on the door of somebody who lives in the community? Who better than that? So we have community health workers that went there, and we did a survey, and we asked a question. Why do you think that people are coming late in spite of having health insurance? The vast majority said fear. And you know what? Fear comes in many shapes and forms. Fear, some women wrote, fear to lose my husband, because if I lose my breast, I may lose my husband. Fear to losing my hair if I get cancer. So they have fear and they prefer not to go in spite of having health insurance. So that is one big thing. And the second one was that they have no time or have to take of somebody else in my family.
Dr. Benjamin, I think in your service as our 18th Surgeon General, you had one or two little programs that address some of the environmental factors that contribute to colorectal and breast cancer. Would you like to tell us a little bit about that?
Yeah,
please?
I did, but as a Surgeon General, you can't have a microphone without talking about tobacco, and particularly tobacco. In the United States, every day, 1,200 people die from cigarette smoke. And that's unacceptable. Each one of those deaths is being replaced by 2 young smokers. We call it replacement smokers. 90% of all smokers start before the age of 18, 99% before the age of 27. So if we could just prevent our young people from taking that first cigarette before age 27, less than 1% would ever start to smoke. However, we're seeing the tobacco companies, and we're marketing to these young people. They're marketing $1 million an hour, $27 million a day, and marketing nicotine's one of the most addictive substances that we know of, and so we know that e-cigarettes and others have nicotine in them. So one of the things we could really stop is just by stopping our young people from ever getting addicted.
So elaborating a little bit more on Eddie's question, 2 of you are here representing our government, our public health service, and Dr. Huerta, you're representing our clinicians. If the 3 of you had to put your heads together to design an ideal partnership to address the issue of tobacco use and its effect on cancer prevention, who would be some other partners that you'd like to see join with you to attack this problem?
I will get the faith communities, I will get the community-based organizations in one side, and I will get the media, the responsible media who really want to get the message out, but I will get people who live in the community.
I agree with that, and we have a strong anti-tobacco community, particularly the junior high kids, the Kick Butts Now kids. They're in junior high. They're strong, but we also have some of the people in the technology world, the Silicon Valley, trying to figure out how to use apps and things. We have others that are investors. We need to involve everyone that we could. The other thing we need is, in these community organizations, we need more funding for these small groups. It doesn't take a lot, but it's often overlooked.
And as a parent, I would say definitely working with the schools and the community-based organizations where kids are involved, the athletics, the dance teams, the cheerleading squads, the football teams, pulling them in to understand the importance of modeling good behavior and talking to kids about prevention early in life.
That's great. Well, I think Dr. Huerta, do you have any other comments about those partnerships? All right, well, I think this has been a really wonderful panel about prevention. Either of you have any other last comments that you'd like to make?
No, I think this is a wonderful opportunity for us to actually really make a difference, and so we thank the Biden cancer, just this whole idea of going for a moonshot, we'll reach Mars.
Just want to say that imagine that our country has a public national public education program through the media and everybody listening, going to work, programs on health and prevention, public health, but also at the same time, thousands of community health workers walking in the communities, spreading the same message. Imagine that.
Absolutely. So partnerships between the community, media, and our public health workers are really key. Thank you so much. Thank you, panel. Wonderful. So as we're in this transition, we'd like to ask Vice President Biden to come back up. And actually, Vice President Biden, we have a question for you to address during the transition. This question is from Twitter, from Empathy Saves. 1 in 3 will get cancer in our lives. This is a national emergency. How do we get Congress, something I think you know a little bit about, how do we get Congress to understand the threat and act to massively increase research dollars?
First of all, I think the Congress is prepared to do that. Let me give you an example. And the 2 surgeons general and doc, as they leave, there's a lot of aspects of this, but in terms of NIH and focusing on cancer research, there's an overwhelming bipartisan support. Let me give you an example. At the end of our administration, after President Trump had been elected, he was president-elect, but we still had the rest of December, November, and January. The Republicans announced that they were not going to have any more appropriations. They weren't going to spend any more money. And there was a proposal called the Cures Act that was $6.9 billion in spending for health care. Of that, almost $2 billion was for cancer and cancer research. And so I was told that there were only, out of 425 members of Congress, there were only something like 175 who would support it. And I was told that there were fewer than 38 members of the Senate who would support it. And I have a bad reputation of being liked by Republicans as well as Democrats in the Senate. I always thought we were supposed to be bipartisan, not a joke. I mean, if you notice, any time we had a problem in our administration, I'd be the guy that gets sent up to the Congress to try to work it out because I genuinely respect the institutions. And I never question another senator's motive. I question their judgment, not their motive. And when you don't question motive, you can actually get things done. So I called 3 leading Republicans who are really solid guys. 1 woman, 2 men. And I went up and I said, look, we ought to be able to get this done. With 6 days left to go in the United States Congress, before the president was being sworn in January, we were able to move from fewer than 175 people in the House to get 398 votes, and in the Senate to get 98 votes to vote for funding over $6.9 billion. Not authorization, money, appropriations. Now, that wasn't because of me. That's because we talked to one another. We went up and I went to the leading Republicans and said, come on. And they all agreed. They all agreed. But what gets confusing, and the reason why it's harder to get more money, is when you talk about other entities within the government that have impacts on cancer, and we know it, you know it, but the average person, it doesn't sound like it has. What does the Department of Transportation have to do with cancer? What was EPA have to do with cancer? A lot to do with cancer. But they're not able to go back home and say, this is for cancer. Because all these folks know that when you talk about NIH, National Institute of Health, it's about health. And they know their constituencies, conservative to liberal, think we should be engaged in public health. And so that's the reason why we're able to get it done. And so that's why I continue to do what we're doing and why so many members of the House and Senate, Republicans as well as Democrats, are supportive of this effort. Because but here's the thing, and Dr. Agus is one of the brightest guys in the field, and he and I talk about this all the time, not a joke, is that we have to show results. The public doesn't mind us spending their money if we produce outcomes, results, results. One of the reasons for these forums that I do is to demonstrate to all of you that there are real concrete results that are occurring. So then when we go back and say, I go up to the Hill or others do and say, we have to spend another $10 billion. We in fact have the public saying to their congressman, no, no, no. I'll conclude by saying, after we pass that almost $7 billion worth of funding for NIH, the President of the United States, the incoming president, sent up his budget. And he proposed cutting NIH by $10 billion after we just added almost $7 billion. You know what the Republican-led Congress did? They said, sorry, Jack, we're not only not going to cut it, we're going to add $2 billion more. Now, is there anything you can think of the Republican Congress has challenged the president on, and without any debate, no, it's not going to happen, Mr. President. And then next year's budget, the Republican Congress, notwithstanding the president's budget, did not ask for more money for NIH, put more money, a couple billion more into it. So as long as we can show results that the public needs are being met, the congressmen and senators in both parties will respond. I am certain. And the more we can demonstrate by what we did here today and we did in the Moonshot and many other people are doing, that we're actually making progress, the more philanthropy rolls in too. Because no one wants to waste the money, but if they actually think something's happening, then they'll get it done. And although I didn't get asked the question, I'm going to answer the question about HPV. One of the things that's important is, you know why it's not working? Because it was associated with promiscuous sex. That's the handle it got. It got that this was, no, but you know that's what happened. That's what happened. They said, you get this, if you in fact take this vaccine, you're not going to get these various diseases for having sexual intercourse and other activity. That's not at all what this is about. So if we want to change it, have the churches, the synagogues, the mosques talk about how it can save people's lives. Talk about, take it to the public, because it's a misnomer. Ladies and gentlemen, Dr. David Agus and his panel. I'm going to get out of here.
Thank you, Vice President. I certainly agree, not getting the vaccine is permissive to cancer. So we have the privilege of having the cool panel. So research and innovation, optimistic, exciting, and I think when you see who the panel members are and their views, it'll get each of you on your edge of your seat for what's going to happen next. So Dr. Jaffe, can you introduce yourself, and then we'll introduce, and then we'll go to the questions.
Absolutely. Good evening, everyone. My name is Liz Jaffe. I'm the Deputy Director of the Johns Hopkins Cancer Center. I'm also the President of the American Association for Cancer Research. And I conduct research in both preclinical models and patients, and I've been developing for the past 25 years immunotherapies.
And a board member of?
Oh, of the Biden Cancer Initiative, sorry. I thought that was implied. Thank you.
So good evening. My name is Julie Grant, and I am also a proud member of the Board of Directors for the Biden Cancer Initiative. I'm also, as a day job, a partner at a venture capital fund called Canaan, and we invest in cutting-edge technologies based upon research and discoveries from leading scientists at American universities, and found new biopharmaceutical companies to try and address unmet medical need, including cancer. It's a really pleasure to be here.
And good evening. My name is Sam Blackman. I'm a physician scientist, a pediatric hematologist, oncologist, and neuro-oncologist. I took a very different track in my career because shortly after I finished my training, I went into the pharmaceutical industry and then subsequently into the biotechnology industry. And for the past decade, I've been focused on cancer drug development, particularly early stage cancer drug development, with a focus on developing new therapies for pediatric cancer and other advanced cancers.
All right. And I'm David Agus. I'm a professor of medicine and engineering at the University of Southern California and head of the Ellison Institute for Transformative Medicine at USC and a proud board member of the Biden Cancer Initiative. So the first question is from Twitter, from Shalan on Twitter. How can we effectively address cost of cancer care without stifling innovation? Or maybe they aren't linked at all.
Perhaps I can take this as the investor and finance person on the panel. But I think, first of all, we really need to talk about affordability. And it's a big problem in our country because a lot of the amazing technologies that we are trying to invest in to make a difference for patients in need don't get to the people who need them because of drug pricing and the design of the insurance plans. And at the same time, we need that revenue in the pharmaceutical and life science industry to finance new cures. And I really think that there is room for drug pricing and insurance plans to change and for there to be innovation, both from the federal government as well as biopharmaceutical companies. It's because we're talking about trillions of dollars, not millions of dollars, but trillions of dollars that are being invested in science today. So I really believe that in that $1 trillion, we can find a way to help with affordability and continue to move the science forward.
Other people have input on that. Do you think they're linked? I mean, are they directly correlated, or is there
I don't know if you can draw a direct one-to-one correlation, but it's clear that this is this is a vast ecosystem, and money flows through all of these sectors within this ecosystem. It's very hard to parse things out, but I do agree with Julie that there has to be ways of increasing efficiency, decreasing administrative cost, and in this vast pool of resources, there are ways to continue to make sure that we have effective and fair pricing, but pricing for new therapeutics that allows for continued cycles of innovation.
But remember the 1990s? There was a biotech IPO every week. Capital markets were throwing money at biotechnology. Innovation was going crazy. And then the 2000s happened. Are we going to get back to those days?
I think coming out of the 2000s, David, we've actually had a number of really innovative products such as gene therapy, cellular therapy, and a number of other tremendous leaps forward in science, despite the change in the economy. And so I really am bullish on the innovation that is coming out of universities today and that markets will continue to pay for them, even if we have other models to think about affordability.
I just want to add, I think where you're going is that we really are in a different time. The 2000s were wonderful. Certainly we made a lot of progress, but we are in a technological and scientific revolution right now. And the progress we're making, just as an example with immunotherapy, in the past 7 years, we've had more than 26 FDA approvals of immunotherapy. And these are drugs that are allowing patients to live years, not weeks or months. So we can't stop this innovation, but the problem is these drugs cost so much. So we really do have to come to a balance, and I think the ecosystem is a good way of putting it. It's a continuum, and they are all interrelated. And we need everyone at the table. We need the scientists, we need the investors, the venture capitalists, we need industry, and we need government at the table because they're different. And patients. Patients are at the center of this whole thing. And I think this is where we need to begin the discussion and be able to come up with some good solutions.
All right, and now we have a question from the crowd. I like saying crowd. Tristan Fitzpatrick, are you here?
He's over there.
You are.
Thank you so much. Hi there. I just want to thank, before I begin, Vice President Biden, everyone on the panel, and everyone across the oncology space for all that you're doing to double the rate of progress against cancer. All of your work is really making a tremendous impact in the lives of people all across the country. So cancer impacts both my professional life and my personal life. In my professional life, I work in communications for the Cancer Support Community, which is the country's largest provider of social and emotional support for people who are affected by cancer. And in my personal life, I'm affected by cancer too. My mother's side of the family has a BRCA gene mutation. So I recently decided to make the very personal decision to go through genetic counseling to see if I'm also BRCA positive. My mother is, my aunt is, my grandmother had it. And so my question to the panel is, what can we do to ensure everyone has access to genetic testing?
It's a great question. Obviously, the Supreme Court came down with a ruling and saying you can no longer patent a gene in our country. And in a sense, it democratized many of these tests, and you saw a fall from prices of $5,000, $6,000 for a BRCA test to now it's tens of dollars or $79, I think is the current price at some of the companies. So it's an exciting time. I mean, what do you guys think? Should every person in the country get a BRCA test? What's the downside with appropriate counseling?
Well, I'm not sure everyone should get the test. I think that the good news is we do have data to tell us who's at high risk. But in those cases, I think people should get the test. There are high-risk clinics. I think anyone with a family history should at least seek counsel from those high-risk clinics. There are algorithms that can determine your risk, and as you point out, the genetic testing is down to about $250. I think the most important part of it is the genetic counseling. And there aren't that many genetic counselors, so you want to go to an experienced center where they can counsel you if you do have the gene.
I might take your question in a slightly different direction, because I agree with everything that you said, but one area where I think we should encourage people to ask for genetic testing is when they are diagnosed with cancer, seeking out mutation testing for their cancer wherever possible. And I think in addition to broad genetic screening, I think that's an important question. One of the things that we should encourage patients, particularly those enrolled on clinical trials or even those not enrolled on clinical trials, is to find ways to access sequencing of their tumors to increase the data set necessary to drive innovation. And if you have been diagnosed, if you have a family member that's been diagnosed, you should consider asking your physician about the utility of sequencing your tumor or doing other genetic testing, because one of the things that we are learning over time is that cancers are really distinct from person to person, even within the same cancer. And the way that we innovate is to learn more about those cancers through those large data sets. So parsing population screening for genes that put you at risk for cancer, I also want to put in a plug, if you will, for tumor sequencing and other genetic testing.
Well, so I think there's two different sequencings that you're talking about. High-risk individuals, that's going to be genome sequencing, whereas patients with cancer, it's going to be whole exome sequencing, so expression of different proteins and genes, which is important because then we can determine therapies. In fact, now we're moving more and more toward what we're calling personalized or patient-specific treatments, and we need the information on tumors. And in fact, now there is one FDA-approved panel, which is Foundation Medicine, and your most insurance companies should be paying for your tumor to be sequenced. So we encourage everyone to have their tumor sequenced. It can provide important information on your therapy.
Yeah, it's quite exciting, as all of a sudden you have the ability of looking at what are the on switches in the cancer and potentially targeting them. And now there's reimbursement for it. This is the beginning of a new era. It's not going to cure cancers, but it's going to allow people to live longer with some of these molecular targeted therapies. All right, one more question I want to push you guys on is clinical trials is something I think we all believe in. It's how we make progress. It's how we advance the field. It's how each of us see whether a drug has benefit or not, or a technology has benefit. Many clinical trials, the data never see the light of day. The trial's negative, the data's never published. Or if the trial is positive, only parts of the data that the company or whoever sponsored the trial wants to get out there. How do we, as investigators, investors, as running a company, how do we change that? How do we make it so a clinical trial that these heroes who put their lives on the line for these drugs, that their data actually helps their children, their grandchildren, their friends, and everybody? How do we change the paradigm so it's not owned by a company, but it's owned by the community?
I'm so happy you brought this up, because one of the most precious resources in all of the work that we're doing are the patients that make the decision to be on a clinical trial. And they deserve the right to know whether or not a drug has actually already failed or something very similar to it has failed. I do think this is an opportunity for the government to be involved and to say if you're taking federal funding associated with research, you really should be able, you have to disclose the outcomes of a clinical trial, in particular randomized trials, because we need to learn faster. We need to know whether or not patients have and have not responded to therapy so we can iterate and make new discoveries and retarget therapies to patients that are going to really respond. So I feel strongly it should be disclosed.
I think there's been some really good progress made in this regard. Disclosures of results from clinical trials being associated with the listing for the clinical trial on clinicaltrials.gov. The European Medicines Association recently has been mandating the release of clinical data sets. And I also think that medical journals have the ability for studies that are published to request that data be provided with that publication or as a condition of that publication. To date, the New England Journal of Medicine, for example, is requiring that you have a protocol. If you're publishing a clinical trial, that you make the protocol accessible. And I think that it's an important first step, but we certainly could go further.
All right, Dr. Jaffe, here's a question from the internet. In advanced cancer, many times clinical trials are done with a placebo arm. Should that continue?
I think that's an excellent question, and I think in my mind the answer is no. And in fact, in talking with people even at the FDA, we're really trying to change clinical trial designs, and I encourage all of you to help us do that because the drugs are good now. The drugs we're testing in phase 1 sometimes have given, in fact, many times are giving patients longer-term life. And I don't feel it's fair or ethical for patients to have to go on a placebo arm. And so I think you'll see that we are changing how we do this, but there's still a number of trials that are randomized. But I think that this is going to change. I truthfully believe that we should change this.
Let me ask another question here. In today's world, there's a lot going on. And so as we finish our session on innovation, what excites each of you? Short answers, but what really gets you excited about how it's going to change the lives of many people here in the room and many people obviously in the country?
I can start. I want to go back to the comment you made about personalized medicine. Mm-hmm. Historically, we have breast cancer drugs and lung cancer drugs and colorectal drugs, and we study each of those tumors based upon their tissue. And what I think is so innovative today is the ability to think on the single cell level about the customization of which therapy is best for every patient, based upon, to the question earlier, the genetic data from that patient and targeting it irrespective of what kind of cancer it is. It really is about what is the gene, what is the protein that is causing your cancer to survive, and how do we get at the core of that to really impact survival for patients.
I will just say that the immunotherapeutic revolution that has swept over the field over the past 10 years has just been, it's been a privilege to witness it, it's been a privilege to be a part of it. And the interaction between the tumor and the host, and what we're learning is that cancer is half of the scientific question. The interaction between the cancer and the human immune system is a huge area that we are just now on the, beginning to learn tremendous amounts about. And I'm thrilled to see how other factors beyond just the tumor and the immune system, but the microbiome and other environmental factors all converge. And we're now able to pull levers and manipulate these systems and create new therapies in these new spaces.
I think also there's many new technologies that are providing several opportunities. One opportunity is to really understand the biology of the cancer before treatment and then with treatment. And many of you who may have been on trials will understand that the reason we need those biopsies is because we can study the differences and see what changes in the tumor with the therapy so that we can make them better. But also, we've been able to use new technologies such as targeted imaging and something we call liquid biopsies, where we take a little bit of blood and we could start to analyze the response to the tumors without having to go for those biopsies. So what you're going to see over the next 10 to 15 years is less invasive ways in which we can assess your response to the therapies.
All right, and I'm gonna cheat and tell you what gets me excited, because I can't handle just being a moderator. It's big data. It's the notion that every time I treat a patient, that information can help me treat the next patient better. And I think we're in an era now where we're collecting this data on patients. We're in an era now where the computing power is there, the ability to actually use machine learning and compare patient X to patient Y and learn from every experience to improve what we do, so I don't have to do the same thing every day. And so with that, I thank you all for being part of this panel. I thank you for your optimism and excitement, because I think the audience feels it. And as part of our changing of the course at dinner, I have a question for the Vice President. Are you ready?
I'm ready.
All right.
I don't know if I can answer it, but I'm ready.
December 7th, 1961 at 3 o'clock. No. What is your advice for dealing with the horrible disease of glioblastoma and the long-term stressors it places on families due to the physical, emotional, and financial stressors of the disease? And obviously, this home tremendous home for you and what the Senator McCain went through over the last year also.
Well, David, you know better than anyone. You've been great. You've talked to me personally and privately and tried to help me with when my son was going through what he was going through. Some cancer diagnoses are tantamount to a death sentence. And stage 4 glioblastoma is one of those cancers. And so when that diagnosis comes, and it was specifically about glioblastoma, when the diagnosis comes, you can do one of two things. You can succumb and say it's over, done, and knowing you're likely to live a while longer and just roll up in a ball. But the other thing you can do is you can have hope. Because what we did is our family and our son, the deal was when we left MD Anderson, I think I've told you this before, great docs we had down there, and Bo got the diagnosis, and I went to the head of the department on neurosurgery, and I said, okay, what do we do now? What do I tell Bo? He was the Attorney General of the state of Delaware, and he was a candidate for governor, and he was, according to the polling data, a lead pipe cinch to be elected. He was a war hero. He came back for a year in Iraq. He was a hell of a guy. And I said, what do we do now? And the doctor looked at me and said, go home and run for governor. Go home and run for governor. And just keep pushing till you can't push no more, because we prayed that that science would outrun the disease. And I don't have to tell you, Dr. Agus knows better than anyone, and this panel coming knows as well, that these breakthroughs, when they occur, they occur overnight. I mean, they've been worked on for years, months, but they occur, and they can occur. But what you should also do is, if you're lucky, you have family or friends, you should begin to plan. You should begin to plan for what's going to happen. In our case, my son had 2 children and a beautiful wife, and so we started thinking about it. And so his brother who was very successful, and his best friend and I, and we started to set up making sure there was a college fund for his kids. Now, if he had lived, we still would have done it, but it was, you know, it was just reasonable. We looked at about what we're going to do about the mortgage on the house, and we had the resources to be able to do collectively. And so there are a lot of things, practical things you do at the same time.
Did you talk about prognosis?
My son, Bo, was a very smart guy, and we all knew what the prognosis was. But as we left MD Anderson, Bo got his brother, me, and his sister in a room, and his mom, and he said, look, let's make a deal. We don't talk about percentages at all. I don't want to hear anything. I don't want to hear that only 1% or 3% or no percent makes it. We're just going to go at this like we're going to beat it. Let's just agree we're going to go at this like we're going to beat it. And so that's what we did. But we weren't naive. It wasn't like we were stupid. We fully understood that the percentages were overwhelmingly against it. And so, but I find that what happens is that you have to be able to have some hope. You have to be able to say that it's possible. You have to be able to look your kids in the eye and say, you know, there's a shot. There's a shot. We can get through this. No matter what happens, we can get through this. And so I really do think the single greatest thing that cancer patients, particularly those with terminal cancers, or viewed as terminal cancers, they desperately need to cling on to hope. And we just talk about it, that it was, who knows? Anything can happen. It can happen tomorrow. And it's possible. It could happen. It could happen tomorrow. And so I say to all those who have those terrible diagnoses, if you have family, if you have friends that can help you, it's amazing. And you can get through this. But, the people I admire the most are the people who got the diagnosis that my son got, the mom or the dad, and they have nothing. They have no help. They have no family. They get up every day and they put one foot in front of the other, and they walk out and they try to continue to go to work, and they try to do their job, and they try to take care of their kids. There's so many heroes. And I'm not being solicitous. There are so many heroes that get up every single morning and go out and face a diagnosis that they know there's very little prospect, but they keep pushing. They're the people that I admire by far and away the most. And by the way, I don't know about you guys, and I don't know about the audience listening, but if you're not a cancer expert to begin with, I didn't fully understand just exactly what immunotherapy was. I tried to learn everything I possibly could, as I went. One of the guys I went to was David and others, to try to learn about what therapies are out there. Todd helped me out too. And what I found out was that 5 years before my son was diagnosed, immunotherapy was viewed as sort of a voodoo science. Nobody took it seriously. I mean, it was like we reached an inflection point. And so the point I want to make to all of you guys is, these guys are figuring out how to get your immune system to break through the camouflage, as a layman would say, that a cancer cell erects around itself.
Don't eat me signal.
Yeah, it really is. So, and so what's happening, they're doing incredible things. Like with Bo. At the very end, the last thing they tried is toward the very end, they injected a virus directly into his brain. A virus into his brain. You say, my God, what are they, crazy? Well, guess what? It was to attract the immune system, in layman's terms, to come and eat up that cancer and kill that cancer. And at first, the folks were giddy about the results. They were overwhelming. But a lot of complications from it. But my generic point is, there's so much promise out there. These guys are going to figure out how to break the blood-brain barrier. These guys are going to figure out how to get to those proteins. These guys are going to figure out how to get to the cancer that's hiding. And so, I just want you to know there is really, really hope. And these CAR T cells, and it's a long story, but there's hope. There's hope. And what we sat there and we thought, well, maybe, who knows? And he lived, God love him, he lived for over 19 months. And a lot can happen in 19 months. So, you know, every time I'd walk out of my grandpa's house, his name was Ambrose Finnegan, he'd say, Joey, keep the faith. And my grandmother would say, no, go spread it. You got to keep the faith. You got to keep the faith because some brilliant people, and they're going to find a way. They're going to find a way. In the meantime, you don't know when it's going to happen. It could happen tomorrow. Someone can go up with a major breakthrough. Tomorrow. So keep fighting. You just got to keep fighting.
Thank you so much, Vice President Biden, for that inspiration. And that is the perfect segue into the third and final session of this town hall. I'm Todd Park, incredibly honored to be a member of the board of the Biden Cancer Initiative. And we're welcoming three amazing leaders as our panelists this evening. And if each of you could introduce yourselves to the audience.
Good evening. My name is Dr. Richard Shilsky. I'm a medical oncologist and the Chief Medical Officer at the American Society of Clinical Oncology. We're the professional society that represents oncologists and other providers who care for patients with cancer.
Hi, I'm Stephanie Joho. I am a cancer survivor and an advocate. I was diagnosed with an aggressive colon cancer at 22 years old. I have something called Lynch syndrome. It's a genetic inherited disorder, and quickly became stage 4, and my life was saved on an immunotherapy clinical trial. So Vice President Biden's remarks there definitely goes right to my heart, because I was one of those people who immunotherapy was right on the cusp, and it saved my life. So happy to be here with you all.
I'm Shauna Butler, and I'm glad you're here, Stephanie. So I'm a nurse economist. I work with a couple of different groups, one of which is exponential medicine through Singularity University. And we're focused on those technologies that have exponential curves, where the convergence point is creating exponential impact and change. And I've recently moved to the Netherlands, where I'm standing up a program there as the Entrepreneurs in Residence, very much focused on how do we formally engage nurses in the innovation agenda.
Fantastic. Our first question this evening comes from Cyril Pettit in the crowd. Is Cyril here?
Great, thank you for the opportunity. So I am the director of a nonprofit here in DC, and our mission is to facilitate collaborations across the public-private sectors to improve public health. And one of the things we've seen in our work over the last 3 decades is that collaboration works when you align incentives and interests. And I wonder in the survivorship space, if you can talk about how we as a community can help to increase the incentives to bring public and private sectors together to focus survivorship not just on length of life, but really on quality of life and averting adverse events associated with therapies. Thank you.
Well, maybe I'll start, if that's okay. You know, survivorship is a wonderful thing. There are 15.5 million cancer survivors alive in the United States today. Many of them face continuing medical problems as a consequence of their therapy or as a consequence of the cancer that they have experienced. They have a risk of recurrence of that cancer, and many of them have a risk of second malignancies further on down the road. So the challenge that we have in a sense from my perspective, in part is the handoff. So as oncologists, of course, we care for these people when they have their cancer diagnosis. We do our best to render them cancer-free, and we're being more and more successful at that. And then they return, by and large, to the care of their primary care physician. And we have to send them back armed with information about what cancer do they have, what treatment did they get, what is their risk of recurrence, what are the possible long-term side effects of that treatment. And we then have to equip the primary care medical community to continue the care of those individuals with the knowledge of what those folks are facing. Because there are way more cancer survivors than there are oncologists to care for them. So it's got to be the rest of the medical community that participates in this, and the knowledge transfer and the handoff is a big part of that.
Stephanie?
Sure, I can add something. Survivorship issues are incredibly important to me, and I think to a lot of us, because thankfully with these new treatment modalities, specifically in immuno-oncology, people are living longer lives, and that's a wonderful thing, but it does come at a cost, and there are adverse events, and I always get really nervous when people talk about these new drugs as if it's just the immune system and it's very benign, but there are real things that happen when you rev up the immune system. So I've dealt with, chronic issues and have many times, unfortunately, felt like certain people weren't really interested in understanding them or really recording them. So I think there needs to be a huge effort, whether it's as part of clinical trials or as part of long-term follow-up, to be understanding what is going on with people, because the truth of the fact is we don't know what's going to happen in 10, 20, 30 years with these new modalities. So I think this is of the utmost importance. I don't know how to answer specifically about incentives, but I do think that there's some incentive there to pharma and to all sectors to really hone in on this issue.
So I would like to expand that discussion of survivorship. There's a whole lot of suffering going on, and we've referenced Bo quite a bit, but I'm wondering about Bo's wife, and I'm wondering about Bo's children. And when we take a look at those folks who have a valiant effort but then do not succeed in their experience with cancer, there's a lot of bereavement that's going on. And we know that those family members are at great risk for all sorts of mental health issues, for their depression, and this goes on for years. And so that expanded notion of what survivorship is, I think, is a really great opportunity for partnerships. When we think about partnerships, too many of our partnerships are limited to the medical space. And most of survivorship, your life, is where we live, work, pray, and play. It's not in a clinical setting. So our medical records really don't reflect our lives. And that's where there's some opportunities for some great partnerships. And when I think about where we're using technology right now, too many people don't have access to the internet. So how are we thinking about, I think Google's digital inclusion agenda is a really important part. And part of this expanded portion of partnerships is we need to be looking cross-sector, because we look very much in the biomedical model. And one of the things, and you will hear me say this quite often, when we think about the problems in medicine and healthcare, the answer is usually a nurse. There are just more of us, and we are everywhere. So from the standpoint of thinking about those partnerships and those survivors, I think that we need to engage a lot more communities and go cross-sector.
Thank you so much. The second question is from John Trent in the audience. John, are you here? John? Well, John had a great question. I'll ask it for him. 85% of cancer patients are seen by community doctors, often in rural areas. How do we deliver cutting-edge therapies and the latest clinical trials to these patients?
Yeah, this is a great question, and it's a great challenge. And first, I should, be sure everybody's aware that many oncologists practicing in community settings do participate in clinical trials, largely through a program funded by the National Cancer Institute called the NCORE program, the National Community Oncology Research Program. And there are 60 or so of these funded community oncology programs scattered all around the country, where at least those oncologists have access to cutting-edge clinical trials. But it's still way too few, and as we heard from the Vice President and others all throughout the day, patients in the traditional paradigm often have to travel long distances to go to a place that has the clinical trial that's appropriate for them. The solution, I think, is we need to flip the paradigm. Instead of making the patient go to the trial, we need to bring the trial to the patient. And that's where technology can really help us. There's absolutely no reason today that any oncologist seeing a patient who is aware of a potential clinical trial can't log on to the internet, get that trial protocol, explain it to the patient, get their consent, and start treating the patient. And and If Amazon can use a drone to deliver a new pair of blue jeans to your front door, they can use the same drone to deliver a new cancer treatment to your front door. So I think that's the paradigm.
So I'm glad you brought up the technology enablement. There are so many examples right now where we're using virtual care. And we, to your point, we are available where patients are. And so there's several hospitals right now that have been bringing that in to provide services to smaller regional hospitals. The other part that I think we're really missing the boat on is using our full workforce. There are nurse practitioners, oncology nurse practitioners, who are brilliant, and from the standpoint of particularly in the rural areas, this is where we are hardest hit, and there's an enormous workforce that's not being deployed, mostly because of legislation. We don't, so many of the states don't offer nurses, the nurse practitioners, full license authority. And so that is an artificial limit on access. And the other part about technology enablement, particularly on the clinical trials, there are many companies working on all of this. And I think a bigger piece is patients becoming better consumers and engaging all of their team. The best resource we have really is the internet. I love the internet. And there's an enormous amount of information and a lot of companies that are thinking about how do we connect patients to trials. All of our technology companies are there to help us on that. So yes, nurses and technology.
There's one other thing I'll add to this, which is even if patients can find the trial that is right for them, they don't always qualify. And that's because, for scientific reasons, trials often have very specific and oftentimes restrictive eligibility criteria. This is something that my organization has actually been working a lot on with Friends of Cancer Research to broaden enrollment criteria for clinical trials so that more patients can participate and the results of the clinical trials are more applicable to the general population of cancer patients. Just yesterday, based on work we've done over the last year, the National Cancer Institute issued a revised protocol template that all investigators are supposed to follow to expand the enrollment criteria for cancer patients to get into NCI-sponsored trials. And we're working now with the FDA to develop guidance documents for industry so that commercially sponsored trials will have the same broad eligibility criteria so more patients will be able to participate.
Fantastic. I think we have time for one more question. This is a two-parter from Miranda Johnson. Is Miranda in the audience? Miranda, hello.
So my question is, what can be done to raise awareness about the challenges that young adults face when dealing with a cancer diagnosis? How can we ensure that all patients and caregivers have access to social and emotional support services at every stage of a cancer journey, starting at diagnosis through to survivorship?
I'll take that one. Thank you. That's a wonderful question. I'll start with the first part. Age is an inextricable aspect of how we experience this disease. When I first got diagnosed, I was 22, so I didn't quite fit into the peds oncology floor, but also when I went into the adult floor, most people who looked like me were there with their grandmothers or their fathers. So I think it is so important to talk about this issue because as all my friends were just starting to figure out who they were and what we were going to do with our lives, this huge life interruption happened. And I think it's so important to seek out peer support. And I think oncologists should be mentioning that. I think nurses, I'm sure, mention that. And just to really, there are so many resources out there. There are some wonderful things about the internet, some not so wonderful things, but one of the really great things is that it connects us. And I think there are, between Twitter and social media and wonderful organizations like Cancer Support Community, Immerman Angels, Patients True Talk. There's some great places to help you connect with peers because it is such an isolating event to have in your young adult life. So to understand what other people are going through, how they dealt with fertility issues, things like that can be truly the most comforting thing because as much as your family and your friends want to be there for you, unless you've gone through it, it's kind of hard to do that. So I really appreciate the question. happy to take on the second part of it.
Yeah, I can't reiterate that enough. We need to be where people are, and our young people are online. And there are remarkable developments with YouTubers, people who are blogging about all of this, the peer-based communities. And what we do find is that there is so much information, not only support, but from the standpoint of dealing with the very practical pieces. And so it is that peer, the experts in the condition, who really guide, and we find, particularly, ZDogg MD, how do we find those people who are actually the really good storytellers, the story doers, and reaching people where they are and the way that they want to be reached?
Fantastic. Well, please join me in thanking our terrific panel. And to close this incredible summit, please welcome back to the stage Vice President Joe Biden.
All of you stick here for a minute, okay? I think this is a really important panel. And one of the things that I think that people don't know is what you just said. You know, I've been to probably 18 to 20 of the major cancer hospitals in the world, from Brisbane to London to throughout the United States. And that population set between 16 and 25 years old is sort of out there. They don't fit any place. And they're scared to death, and their moms and dads who've never experienced it don't have any idea what to do. And I think what you talked about really matters. One of the things that we tried to do, as Todd knows, in this effort, and before we're going to continue to try to do, and looking to you, nurses, is that we need navigators. We need people who can walk you through.
We are here for you.
Well, I know you are, but we're not nearly organized enough. We're not nearly organized enough. And so what happens is that people don't know quite what to do. I'll give you an example. I remember when I first got elected, I was 29 years old, to the Senate. And I wasn't old enough to be sworn in. And so I was down in Washington. I got elected on November 3rd, I think it was. And I was down in Washington on December 18th interviewing, and I had just turned 30 in the meantime, make me eligible, interviewing staff. And I got a phone call from a first responder, a young woman who was so nervous, she got on the phone and said, "Your wife and daughter are dead. They just got hit by a tractor trailer and were killed. And your two boys you better come home." And I remember going home, and Teddy Kennedy, who was an incredible guy in terms of being an enormous consumer of healthcare and understanding and being connected throughout the country as to who the best people were. I remember going back to the hospital and spending time in the hospital with my two boys. And one day, the third day that they were there, and they were there a long time, I walked in and there was this, turned out to be this brilliant psychiatrist from one of the major hospitals in Massachusetts who were there to want to talk to me and talk to my boys, because he said, "You better be prepared to figure out how to talk to them." Well, I don't see that happening nearly in the cancer space. It was, and no, but I mean it, and I'm not trying to be critical. I just don't think it's thought of that way. And so you sit there, and I watch my two grandchildren, Beau's children, and I watch them react. And thank God, with a lot of love and support and a big family, they're doing pretty well. But things like we're at the beach, and my little grandson jumps on top of me, and we're playing in the sand. He says, "Pop, you smell just like Daddy. You're not going to leave me, are you?" That happens all the time with families all over. And it's hard to make the distinction between, is this a normal reaction to dealing with tragedy, and it takes time because so many people deal with tragedy in hundreds of different ways? Or is it something that warrants intervention, professional advice as to where to go? And so the other thing is that I think what you're all talking about here is just the mechanical things of being able to take pressure off of families. Being able to not have, kids lose daddy and they see mommy trying to figure out, how do I pay the mortgage? How do I, thank God that's not the case in my family, but it affects kids. It really affects them. They know so much more. They absorb so much more than you think. And so one of the things that I think coming out of this summit, and we'll see more, are a number of commitments have been made how to ameliorate the pressures, the multiple pressures, whether they're financial, psychological, whether they're physical, on families who have gone through or going through serious, serious, serious pain. Because that's what it is, it's pain. It's pain. And so the second thing I want to mention to you, and Todd was, this guy was an incredible asset in our administration and knows more about technology and breakthroughs than I can ever possibly learn. And he's put so much together. I really mean it. I'm not being solicitous. I'm being deadly earnest. One of the things that we did when the president put me in charge of the moonshot and gave me authority, presidential authority to run it, as Todd will tell you anyway, that, everybody knew when I spoke to the administration, I spoke the same authority as the president. The president was going to back it up no matter what. And one of the things that we found out was, we talked about, NIH spends $5 billion a year in giving grants for cancer research and cancer trials. Well, what we found out, remember? We found out that 85% of those, and they're required under the law, when the trial is finished, the outfit that got the grant is supposed to file public notice, file exactly what the results were. If they failed, that they failed. If they succeeded, they succeeded. We found out 85% of the people who got this money never did it. Never did it. Because if they failed, they didn't want people to know they failed, but you learn from failure as well as success. And the second reason is if they succeeded, they would hide it behind a wall, a publication wall, where you got to pay $150,000 for a journal to get the information you don't get at all. And so the president gave me authority, and I had an idea. I said, okay, for every day that you go beyond the day you're supposed to file, you personally are liable $10,000 a day. And as they say in Southern Delaware, all of a sudden, all these researchers, they had an altar call. They saw the Lord. All of a sudden, I'm not joking, but think of that now. Think of that. All the data and information that was never, ever, ever made public. And how other researchers could benefit from the success or failure. So there's a lot of things that you, the voters, have the power to insist that we do to get more collaboration and more sharing of information and data. And you talked about, doctor, and you're one of the best, you talked about these trials. Well, you may have a great oncologist up in Bemidji, Minnesota. I use that again because it's a small place and it's one of the coldest places in the United States. And he can get, at a reasonable price, your cancer genome sequenced and he can analyze it. But what happens is that he has real trouble getting access to trials. He has no idea where the hell the trial is. You can't go anywhere. Tell me where you go to find out what's trial.
Well, there are places, but the information is very incomplete.
You got it. As the old joke goes, don't kid a kidder. What we did is we went to Todd's guys and said, okay, there was a site at NIH to say you can find out what trials are going on. Well, it wasn't readable. It wasn't understandable. So we went to the tech guys that we brought in from the Valley, and said, can you design a website for us? So you can click on, as a doc in Bemidji or a patient, and say, I have this particular cancer, this is in plain English, and you can find out where every trial is. The trials that are near you, the trials that are far away, and be able to determine whether they're, but think about it. One of the things, and I'll end with this, one of the things that we talk about, and the guy who heads this cancer operation for me says it best, is a lot of people, we want a system that people think already exists. I can go on my phone and find out what movie is playing in the movie theater in Laramie, Wyoming right now. Why can't I go on the phone and find out every trial that's available for and what kind of trial they are? Why can't I do that? Why can't I do the things that any other business would be able to do in a normal way? So I'll conclude with this. One of the overwhelming reasons why I asked the president about moving forward, and he was way ahead of it on the moonshot, was that we got to change the culture. When Richard Nixon declared the war on cancer, and he meant it in the 70s, he really meant it. He was committed. He had no army. He had no soldiers. Everybody at the time thought there was basically a single cancer, that there was, and that was it. And the model was Jonas Salk was going to go into the laboratory and find the silver bullet and cure it. Well, we now know, and I'm no expert, but I've spent 3 years trying to learn, there's over 204 or 205 distinct cancers requiring distinct therapies. They're different. They're different. Number one. Number two, you go out there and you find out that there's so much more we know. You heard Dr. Agus say, you know, what big data is so important. Well, guess what? There is what we had at NIH. We had 14,000 people who had their cancer genome sequenced and was in one place. You could go to research, or they had the tumors. And by the way, the other thing I found out, because, you know, I went to law school because I wasn't smart enough to do anything else. But you docs, you know, there's no protocol for taking a biopsy. So all these biopsies out there, and you're going to send a biopsy to be able to research? Docs say, I can't use that biopsy. I don't know whether it's been sitting on a desk or in a laboratory for, I mean, why isn't there a single protocol to be able to learn from all of the data that's there? So what we did was, we came along and we said, why don't we set up a new place where all of the cancer sequencing, all the genomes, all the records, everything about patients is going to be at the University of Chicago. And any scientist from anywhere qualified can have access to it. Can have access to it. Well, now, Greg, how many at the university? Now there's 150,000 individuals that have given or accessed all their data. And guess what? Todd was one of the ones that convinced me when the president gave me authority to call cabinet meetings and begin to bring together the stakeholders and the federal government on cancer. I called in the Department of Energy. Everybody said, what the hell are you calling the Department of Energy? Well, the Department of Energy, we can now do 1,000,000 billion calculations per second. You hear me? 1,000,000 billion calculations per second. And before this decade is out, we're going to be able to do 1 billion calculations per second. Now, how many Nobel laureates sitting 24 hours a day before a screen, examining all that information, are going to be able to learn as much as you can learn in 10 minutes if you had 1,000,000 cancer genome sequenced in front of you and wonder why the same cancer you're diagnosed with that worked on you, the therapy, and didn't work on you? So there's so much more we know. But that's what we mean by big data, being able to accumulate this data to learn so much more from. But it's not because docs and nurses and clinicians and researchers are bad guys. They're the most devoted people I've ever worked with. But guess what? The culture is totally different. Y'all don't share well. You don't play well in the sandbox together. No, I'm not. And by the way, when I said this early on, we started this, the editor of the New England Journal, he subsequently found some pushback, but he said that Biden's encouraging data parasites by sharing the data. Well, guys, what are we doing? Why is there not automatically all this data shared for any person to have access? So, but it's beginning to change. As the doc can tell you, it's beginning to change. It's really beginning to change. And, you know, I'll give you one last example. There's a lot of pharmaceutical companies who are doing research on particular cancers. And they may have a therapy or a drug they're testing that may take them, if they went through the whole testing process, it could cost them $20, $30, $40 million to go through the process. But we decided to set up a thing called a drug formulary. If these aren't patented already, and you each are working on the same cancer, and you each have different therapies, we now have a system where we go in and look at yours and say, well, the intellectual property value of your contribution could be 30%, yours would be 18%, yours would be whatever, and it's worked out ahead of time, and you agree that if there's a cure, because we're finding out that multiple drugs, like with AIDS, may be the answer. This is what's only beginning to happen now. So now guess what? There are now, how many on the table? There are 40 different therapies, drugs, that have been put out on the table for any researcher to be able to access, including, I think it's 12 major drug companies, and said, we're in. So now the young woman asked about incentives. The incentive is, instead of spending $40 million, if some brilliant young researcher comes along, takes all four of those drugs and comes up with an answer, you already know you're going to get 30% of whatever that is. And it's going to be worth a hell of a lot more than $40 million or $10 million. And so there's ways to do this, to keep incentives, to not punish any researcher or not punish any drug company or not punish anybody, but to move much more rapidly toward finding answers. And when we did this, when we did the thing out at the University of Chicago, we were told that, well, it's not going to matter a whole lot. Well, guess what? There's been, within 4 months, there were over 8 million hits. 8 million times researchers went in and sought access to the information that was now accumulated. I was able to get 10 countries to sign on to Memorandum of Understanding where they send their data to that facility. It's a worldwide thing that's happening. So this is all doable. But it's not because folks are bad guys. It's just a culture. Back when, and I'll end where I began, back when Nixon did this, there was no ability to share data. Even if a hospital wanted to, there was no way they could physically share the data. We didn't have the means. We didn't have the capacity. It all exists now. And because of what you guys have done, there's so much more data and information out there. And so I am optimistic. I'm not falsely optimistic. But I think I know the history of the journey of this country of ours. When we set our mind to get something done, and we start thinking as Americans rather than as individuals, when we start thinking about the public good, there's not a damn thing we cannot do, and they will solve it. Thank you. Thanks. There's any angels in heaven, you're all nurses, I told you that. I'm proud of you. Presumptuous of me. Doc, you're the best. Keep the faith, everybody. Thank you.